Ladies and gentlemen, it's very nice to be here to talk to you, and I'm glad that few people managed to come here. My name is Kofler, I'm from Germany, and I would like to start giving you a talk about the scar treatment using radiofrequency microneedling. To start first, we have to clear the mode of operation of the radiofrequency needling for all of you who don't know the procedure as well. We have sterile needles penetrating the uppermost layer of the skin. It depends if you use this machine I show you right now. We have variable depth for the needles between 0.5 and 3.5 millimeters, so you can adjust it on every 0.1 millimeter to reach the layer of the skin you want to. You have the penetration of the epidermis with these very, very fine needles without damaging the epidermis, which is very important, and stimulate simultaneously the deeper layers with a radiofrequency pulse. So you have a very short and targeted heating of the tissue in a very specific layer. The objective of the whole procedure is to stimulate the body's own mechanisms for skin removal, for skin renewal. The induction of neogenesis of elastic fibers and for collagen fibers is very important and is the main column of this treatment. So we have two different treatment approaches if we use RF needling, which is first the needling you knew for years, which is a gentle perforation of the top layer of the skin and the mechanic induction of the neocollagenesis. And we have the radiofrequency treatment part, which targeted heat impulses in the deeper skin layers. The desired results of this treatment are the reduction of fine and even deep wrinkles and the reduction of scars, something we talk about today. We stimulate the body's own regeneration processes without the introduction of foreign materials, which is important for some people, which is a very important also key point for this procedure. You do not have any foreign material, you do not have any reactions to this foreign material. You use really the body's own mechanisms of renewal. The skin feels cushioned from the inside out. You have more tissue material that cushions the skin. You have a firmer and smooth appearance of the skin and a very natural appearance of the skin, which is important if you use it for an aesthetic point. So this is how you see it on this touch screen of the machine. You can adjust various parameters. First of all, the strength of the radiofrequency pulse in percentage. You can adjust, of course, the depth of penetration, the pulse repetition time, which makes you very fast. I usually use 0.2 seconds. And the duration of the radiofrequency output during the time of the needle penetration and the output during needle penetration delay and the repetition frequency. So you can adjust every parameter on a single basis. You can be very fast, you can be deep, you can be more superficial, whatever you like to target. And we have two types of needles. We have insulated needles and non-insulated ones with 25 or 49 needles per head. And you can see this illustration of how this needle impulse works. We have the non-insulated type where the whole needle gives this radiofrequency impulse, or the insulated with only the impulse on the tip, resulting in a drop-like reaction of the skin. You can see it here in this histology slide, which is from 0.5 to 3.5 millimeters, and you can really see how beautiful the epidermis is in, for example, the deeper 2 and 3.5 millimeter depth. The epidermis is not touched at all. You can see this little damage from the very thin needle, but you can see the reaction on the deeper layers of the dermis. When we talk about scar treatment, we have to think about what are scars, and we have a lot of different types of scars. We have, of course, surgical scars. We have like this ice pick scars you see on the picture from Acne, and you can also have autoimmune induced scars like here in this livedo vasculopathy. We have different scar types. There is a classification according to Musto that differentiates scars into mature scars. You all know this. It's very skin colored, it's very light, it's flat, it's slightly below maybe the level of the rest of the skin, and immature scars on the very beginning. And then you have very unpleasant type of scars. The linear or flat hypertrophic scar, typical erythematous, raised, possibly itching, very annoying for the patients. You have atrophic scars typically after acne. It's pale, there are sunken spots, you have different types of these atrophic scars, usually looking like ice picks or like little boxes. And you have keloids, erythematous, sometimes nodular, always itchy, sensitive scars and tumor-like nodules exceeding the initial wound edges. And we have to talk about evaluation of scars, because usually the patients have a very subjective way to evaluate their own scars. There are patient scores. A very important one is the POSERS, but also the Brisbane burn scar impact profile. And we have objectifiable parameters like color, like thickness, like the extent of the surface. We can all measure this by colorimetry, we can do biopsies, and we can do 3D reconstruction of the area. And there are examiner scores. That is important if you do studies to determine if your treatment is working. A very widespread way of evaluating scars is the Goodman and Barron's scarring system, also used for acne scars. And I show you this because I show you some data from different papers using the Goodman and Barron's score later. So I'm from Germany, and I brought you something from the very recent German guidelines of treating scars. They do not say, unfortunately, something about radiofrequency needling, but they do say something about microneedling, and they explain the mechanisms of microneedling, the implementation of the microneedling for scars, and they give an expert opinion on the treatment options we have. So if you follow this guideline, you can see a very strong consent for microneedling alone or in combination with drugs as a needling-assisted drug delivery are recommended for hypertrophic scars. And the treatment of keloids with microneedling is of course not recommended. But we have a recommendation for treatment of scars using needling devices. But we have to focus on the title, and I translate for you, it's about hypertrophic scar and keloids. It says nothing about other types of scars, nothing about atrophic scars. So we talk about first about this hypertrophic linear scars, and I brought you some data, quite recent data. It was a study with 20 patients with hypertrophic scars after burns. It was a very interesting study because it was a split-phase randomized study with 4 sessions of radiofrequency needling compared to fractional laser every 6 to 8 weeks. And they did both POSERS, this patient-oriented score, and histology, which is very interesting because histology is typically not used in the studies. And we find better POSERS, but more post-inflammatory hyperpigmentations and significantly more downtime for the fractional CO2 laser, something that I experience in my daily practice as well. We have another, this is a case report from some years ago, hypertrophic scars, skin type 4, radiofrequency needling, and topical post-interventional steroids plus botulinum toxin, and a clear improvement after 3 weeks, which is very fast. The authors believe that it's the combination therapy of steroids, botulinum toxin, and the radiofrequency needling, also here in hypertrophic scars. When we talk about acne scars, we usually talk about the atrophic scars. I told you about the pale, sunken spots with different subtypes. We have the typically rolling scars, which are bowl-like or bowl-shaped, the ice pick scars, or more box-like shaped scars. Radiofrequency needling and treatment of atrophic scars also play a very important role. We have this quite older data from 2012, 13 patients with acne scars, and all of them experience 3 radiofrequency needling treatments every 4 weeks, something we do quite similar, 4 to 6 weeks. And we had a medical assessment of the scar severity that was significantly improved after 1 and 3 months respectively, with even an improvement after the 2nd and 3rd therapy. The subjective patient assessment was significantly improved in terms of wrinkles, color tone. They experienced more brightness and less pigmentation, the firmness and the scar texture. And we have a very high satisfaction of patients. And if you combine satisfied and very satisfied. You have more than 67 to 92% of patients that are satisfied with this procedure. Something similar found in a recent study for RF treatment every 4 weeks, and a very interesting way of evaluating this with the confocal refractant microscopy and 3D imaging, and we found a clinical improvement in all these patients with significantly better results for the subtype of boxed scars, but a reduction in scar depth of all the subtypes of scars, and which was very important for me in this finding, a collagen remodeling with restoration of the reticular structures, something that you very want to have. You want not only have an increase of collagen, but also this cross-linking of collagen fibers. And this is something they found also in this study with radiofrequency needling. This is a study from India, which is important because only skin type 3 to 5 were included, something that it's sometimes difficult to treat with lasers. They had moderate to severe acne scars and 4 radiofrequency needling treatments every 6 weeks. And also here we find improvement according to Goodman and Barron score I showed you before by 2 degrees in more than 80% and by 1 grade in about 20%. More than 2/3 of all patients showed a moderate to very good improvement, which is an important result, especially in these skin types. There is also a direct comparison of RF needling and fractional CO2 laser in atrophic scars. They had a baseline, 2 comparable test areas and randomized it. So very well performed study, and they had the needling and the fractional laser with standardized multi-layer techniques from the depth to the surface area, and then blinded evaluation of clinical pictures after 1 and 3 months, plus subjective perception, plus local skin reactions and several other parameters. And the results were that an equally good improvement was observed objectively and subjectively for both of these techniques, but more erythema, more local skin reaction with a fractional laser, and the patients found that the radiofrequency needling was a little bit more painful, which is something I cannot emphasize. Typically our patients, they rated about the same, even less painful for the radiofrequency needling. I believe it's a matter of local anesthesia also here. For the end, I would like to show you some examples of scar treatments, especially in these atrophic scars using the radiofrequency needling. You can see here very good results of atrophic scar treatments. For example, here before the treatment of the cheeks of this lady, after 1 gentle treatment and after 2 treatments. Between these treatments were about 4 to 6 weeks. You also have these results after 2 sessions in a partly inflammatory acne situation as well, with quite low radiofrequency on times. I usually use higher radiofrequency on times than our colleague from Istanbul, but also very good results with this low RF on times. Also here only 60 milliseconds. I usually use, depending on the patient, 150, 200, 300 or even more. But also after 2 sessions in this inflammatory situation, we see a clear improvement of acne and of the atrophic scarring. So if I'm allowed to summarize for you the last minutes, the radiofrequency needling shows very good results for scars. We have radiofrequency microneedling and topical therapy for hypertrophic scars. In different guidelines recommended. We have a radiofrequency needling option for atrophic scars with very good results, very low downtime. It's very comfortable for patients with quite quick results. The treatment of atrophic scars is also possible in skin type 3 to 5. And we have results comparable to a fractional CO2 laser with less downtime and few skin reactions and the risk of hyperpigmentation. Thank you very much for your attention. I believe we do a question and answer session after the second talk, and I would like to give over to my colleague.